I'd like to thank the Congress for giving me the opportunity to present my work. I have nothing to disclose. Insulinomas are rare pancreatic neuroendocrine tumors, and surgical resection is the only curative modality. Unfortunately, given their small size and relatively even distribution throughout the pancreas, they're notoriously difficult to localize. We can think of localization in two different arms, with one being preoperative and the second being intraoperative. Within the preoperative modalities, there's non-invasive and invasive. Non-invasive being axial imaging with CT and MRI or octreotide scanning, and invasive with selective arterial calcium stimulation, or we'll refer to as calcium stim, and endoscopic ultrasonography. Intraoperatively, the mainstays is ultrasonography and, of course, direct palpation and visualization. At our institution, preoperative localization is essential for us. So this reduces the risk of pancreatic re-exploration and the associated morbidity of operating on the pancreas the second time. And most importantly, it facilitates patient counseling for a planned operation. So the difference between a Whipple and a distal tail enucleation is enormous, and something that a patient should certainly have an active participant in the conversation. Selective arterial calcium stimulation is certainly not a new technology, and despite advances in radiographic imaging over the past 20 years, it remains the most sensitive preoperative localization technique for insulinomas. And I want to give appropriate credit to Dr. Doppman, who was the pioneer of this imaging technique for insulinomas back in 1989. So we sought to review our institutional localization practices and compare modalities with the goal of improving preoperative localization of insulinomas. To perform this study, we reviewed all of our surgically resected insulinomas between the years of 1995 and 2016. This included 43 pathologically confirmed insulinomas. 5 were excluded for the diagnosis of MEN1 or necidioblastosis, and 1 had insufficient data to review. This left us 38 patients, and accuracy of localization techniques were compared to tumor location on surgical resection. To review how calcium stimulation is performed, just briefly, visceral angiogram is performed through groin access, the femoral artery. Central venous access is obtained and the hepatic vein is cannulated. Calcium gluconate is injected selectively into the GDA, SMA, splenic, and hepatic arteries, and following injection into each of these respective arteries, plasma insulin levels drawn from the hepatic vein at serial time points beginning at 0 up to 120 seconds post-injection. And just to review our regional distribution, the GDA and SMA is supplied to the head and neck, which is considered localizing in that region, and splenic artery is localized to body and tail. The hepatic artery is injected and stimulated, and levels are drawn to evaluate for metastatic disease. And with all that, it spits out this nice graph of information. And we can see here, this is a nice example of a localizing scan to the splenic artery here, and this is seen as a twofold increase from baseline as their plasma insulin levels, and this patient did indeed have a 1.3 centimeter pancreatic tail lesion that was localized. Overall, our patients were predominantly female with a median age of 52 years. Our tumors were evenly distributed throughout the pancreas, which is consistent with the currently published literature, with 39% in the head and neck, 24% in the body, 32% in the tail, and 5% were multiple tumors synchronous. Our median size was just shy of 1.8 centimeters. 55% of our patients underwent an open operation, while 45% were laparoscopic. 53% of these patients had a parenchymal sparing operation with enucleation, and 47% had a formal parenchymal resection. Our cure rate was 95%, with a mortality of 2.6% and a pancreatic leak rate of 16%. Now, when we look at our localization accuracies of all 7 modalities that we studied within our cohort, this is an order of descending localization accuracy, with the most accurate being the first one right here, intraoperative ultrasonography. And again, this is an intraoperative technique and not necessarily preoperative, but we know from the current published literature, and is also consistent with our data here, that is the most sensitive of all, both intra and pre. And about 92% localization accuracy on our study here. The next most accurate is calcium stimulation at 88% accurate in our cohort, and about 90% of our patients underwent calcium stimulation within our population. Followed by CT scan, which is about 66% accurate in localizing. Endoscopic ultrasonography had a similar accuracy of 66%, but it was only used in about 15% of our cohort, so very infrequently used. MRI had even less accuracy, about 46%. Octreotide scanning in the 30s, and similarly, angiography was about 33%. And it should be noted that angiography itself wasn't a separate procedure. It was in conjunction with the calcium stimulation testing. All patients who underwent calcium stim also had a visceral angiography. This was helpful for delineating anatomy and identifying any aberrant anatomy or replaced right hepatic artery that would give us inaccurate interpretation of calcium stimulation testing. When we look at multimodality imaging, we see that patients who only underwent a CT scan alone, so this is no other imaging modalities, just a CT scan, localization accuracy is about 66% still. Calcium stimulation alone with no other preoperative imaging, and again, these are smaller cohorts than the prior graph that I just showed you. Calcium stimulation alone with no other additional modality was about 80%, and the two combined increased the accuracy to nearly 100%. So all these patients who underwent both a dual imaging approach with a CT scan and a calcium stimulation testing were able to localize all of their tumors preoperatively. And most importantly, when calcium stimulation was used in 4 of our patients, it localized regionally when no other modality was positive. So CT scan, MRI, octreotide, and endoscopic ultrasound were all negative. In 4 of these patients, about 10% of our population, that the calcium stimulation testing was the only one that localized this patient preoperatively. And on these 4 patients intraoperatively, they also underwent, as an adjunct, intraoperative ultrasound and direct palpation. 2 underwent enucleations and 2 had a formal pancreatic resection. Additionally, for our 5% of our cohort that multiple synchronous insulinomas, these were only localized with calcium stimulation testing. And as we can see here, this is just an example of our graphical output of a patient who had a CT scan that localized an insulinoma to the head only, and subsequently underwent calcium stimulation testing that localized to the head, which, as you can see here, this GDA stimulation as well as this proximal splenic artery was stimulated. And indeed, on resection, the patient had 2 synchronous lesions. Some important limitations to note from our study: this is a single-center retrospective review of a small study population in a relatively rare disease, and that calcium stimulation testing requires experienced interventional radiologists, not a benign procedure, although our risks were very low in our own cohort. We acknowledge that this is an invasive procedure. In summary, preoperative localization facilitates patient counseling, preoperative planning, and reduces risk of reoperation. And our institution's 18-year experience here is reviewed with the surgical management of insulinomas. Calcium stimulation remains a safe, highly accurate localization modality, and when combined with calcium stimulation and CT scan, it's highly predictive of cure. Thank you, and I'm happy to take any questions.